Hi, this is the third video on headache. Cluster headache. Cluster headache is often confused with a common migraine, but it is different. It occurs in males much more than in females. Onset is usually sudden and at night. It occurs over or above an eye. It may radiate to the front and side of the head. It may last from 15 minutes to 2 or more hours. Episodes of cluster headache can last for weeks. Tearing of the eye, a nasal discharge, and drooping of the eyelid may accompany the headache. There is no cure for cluster headaches. The goal of treatment is to decrease the severity of the pain, shorten the headache period, and prevent the frequency and severity of future attacks. Treatment can include oxygen. Briefly inhaling 100% oxygen through a mask at a maximum rate of at least 12 liters a minute provides or can provide dramatic relief for most who use it, usually within 15 minutes. Triptans, the injectable form of sumatriptan, called Imitrex, which is commonly used to treat migraines, is also an effective treatment for acute cluster headache. Prevention is part of the treatment program your physician will address. The physician will pick the appropriate medications to prevent or reduce the occurrence of cluster headaches. Temporal Arteritis, also called Giant Cell Arteritis. It is a result of the inflammation of blood vessels. The pain is usually on the side of the head and can be associated with the scalp being sensitive to touch. It usually occurs in those over 50 years of age. The pain may be severe and burning. It can come and go. It presents daily and tends to be worse in the morning. Stress may be a trigger. There can be intermittent blurring of the vision also. The physician can order a sedimentation rate to see if there is an indication of inflammation in the body. Sedimentation rates are usually elevated in temporal arteritis. If the physician feels that temporal arteritis is the diagnosis, then the patient will be treated with steroids immediately. Delay in treatment could result in permanent damage to the patient's vision. Definitive diagnosis requires a biopsy of the temporal artery. Frontal sinusitis. Frontal sinusitis does not normally cause headache pain, but it is important to consider when patients present with headache. The pain is usually in the forehead area and is dull or throbbing. It can occur throughout the day. It is usually worse in the morning. It is usually associated with an upper respiratory infection. Initial treatment is with antibiotics such as amoxicillin, augmentin, or doxycycline. If sinusitis does not resolve, then referral to an ENT physician should be made. A sinusitis that is neglected can result in serious complications and should not be considered a benign disorder. Subarachnoid hemorrhage. This is a cause of headache that must always be considered when the headache is of sudden onset and intense. It may be localized to the back of the head. There can also be pain and stiffness of the neck. The patient may have a drooping eyelid. There may be other neurological symptoms. A CT or MRI will be ordered. If the CT or MRI cannot aid in making a diagnosis, a lumbar puncture must be done. When subarachnoid hemorrhage is suspected, then immediate action must be taken and immediate referral made. Now, when an individual has a headache, when is it important to refer that individual? When a hemorrhage is suspected, referral must be made. Migraines that do not respond to treatment must be referred. When neurological signs appear, such as confusion, neck stiffness, muscle weakness, convulsions, dizziness, or personality changes. When the onset of the headache is sudden and without a previous history of headaches. A recurrent headache in a child must be referred. A headache that wakes the patient at night should be referred. There are other reasons for a referral, but your physician will make a referral when appropriate. Well, in the 3 videos, we have covered the types of headaches normally seen in a primary care office. I hope this helps. Have a good day.